Hello, my name is Dr. Nicole Van Ness, and I am a licensed marriage and family therapist and AAMFT approved supervisor. I'm coming to you here from North Texas. Texas. I did all my training and graduate work and initial experiences in Southern California. And now I'm here in North Texas, where I have a private practice, Connected Couples, and I also am an adjunct faculty at Southern Methodist University. I specialize in sexuality, couples and sexuality, as well as individual sexuality. And something that I've learned in my work, especially coming, from California to Texas, is that a lot of folks don't fully understand what it is that sex therapists do. So I'm here to talk to you about that. Another interesting distinction that I've noticed is sort of the geographical differences in perspectives about sexuality and approaches and beliefs and what people talk about and what people don't, what people think about sex and how they treat it. And I've noticed quite a big difference between California and Texas in terms of viewing sex in, a negative way. I think our society is kind of schizophrenic about sex. We, on the one hand, have sexually graphic imagery everywhere. I mean, you can't look at any billboard or TV commercial or social media posting without seeing a lot of hypersexualized things. And at the same time, there's a lot of taboo and prescriptions against being too sexual or too open or things like that. And that's also geographically defined as well. I've noticed big differences in the, just general openness and how people talk about sex or don't, and what's not considered okay to talk about in polite company. So being a sex therapist, moving from California to Texas, I've noticed a lot of people here refer more to sex addiction and sex addiction therapy. I'm a sex positive person and therapist, and so I don't see sex from the addiction standpoint. That's not to say that I, invalidate that work, because I think there is a lot of valuable work being done with sex addiction treatments. At the same time, I tend to approach it more from a health and positivity and vibrancy perspective. So I'm here to today introduce you to kind of some of the differences in perspectives a little bit. I'm going to, briefly overview sex addiction and out of control sexual behavior, sexual compulsion. Those words kind of get thrown around, but also I'm going to focus a little bit more on actual sex therapy that's not addiction focused. So I'm going to go ahead and share my screen and show you the PowerPoint, and hopefully you can still hear me as I go. Okay, so the title of the presentation is The Multiple Facets of Sex Therapy. It is not just about addiction. Also, I forgot to mention that I am licensed in both California and Texas as an MFT. Okay, so our objectives today, again, just to kind of distinguish between sexual health, sex therapy, sex addiction, out of control sexual behavior perspectives, to distinguish between sex therapy and sex addiction therapy. And again, I'm going to focus more on the former than the latter, which is, sex therapy for multiple issues, not just sex addiction. And then I'll give you two models for sex therapy, one of which you could actually start using in your practice today. Okay, so when I give this presentation live, I usually ask people what comes to mind for sex therapy. Some of the things that people say are the show Masters of Sex, sex addiction, sexual dysfunction, those sorts of things. And so I figured I'd also share with you kind of some of the reactions that I get. And I'll start on a personal note. My mom's reaction when I told her that I was going to specialize in sexuality, And the look of horror on her face as she says, oh my goodness, my daughter is going to be having sex with people for a living. And so I realized, even as a medical professional, my mom, I had to teach her sex therapy is not the same as sex work. And no, I'm not going to be a sex worker. And that is kind of not what this is about. So it was just kind of this comical reaction of panic that she had until I, explained a little bit further. Now she thinks it's fantastic, but that's another story. So some of the common questions I get asked from potential clients is, do you watch? No, I'm not going to watch you have sex. Do you touch? No, I don't engage in any sexual activity with clients or anything like that. Another concern that a lot of people think is I'm going to sort of push them towards more behaviors or use of toys or things like that they're really uncomfortable with, that I'm going to have to, push them into kink or BDSM or things like that, which if you're into that, fantastic. But if you're not, I'm not here to do that. So then the next question is like, oh, okay, so then it's sex addiction. And so this led me to put together this presentation to kind of teach people, there's a lot more to it than getting super kinky, than being hands-on, or, working with addiction. And again, I'm using the kink as sort of the colloquial and not in terms of the kink community, which would be a whole different talk, which I would be happy to give. But I'm not meaning that in a judgmental way at all. I'm just referencing the colloquial use of the word that people use when they're asking me questions. So then the question is, what do I do? And I will, and not just me, but sex therapists in general. And so I'll launch into that a little bit later in the presentation. But for now, I will go on a little bit of a tangent in talking about sexual health perspectives and then also sex addiction. So the sexual health perspective, Douglas Braun Harvey out of San Diego summarized the World Health Organization's definitions of sexual health. And it's based on these 6 principles. The first is consent. And first and foremost, consent is critical. Consent means not only saying yes, but being able to say no. And that's a big distinction that a lot of people don't quite understand. If you've ever seen the Consent and a Cup of Tea video on YouTube, if not, I highly recommend it. It's a very good way of sort of teaching consent in a witty, but really impactful way. But consent is important, that yes, that everyone involved in the sexual encounter is willingly there. And not only are they willingly there, but there's also enough safety in the dynamic that they can say no to sex without there being harmful or manipulative or abusive consequences to that. And so consent is key. The second is honesty. And honesty is about a lot of things. Why are we here? What, in terms of the sexual encounter, what are we hoping to get from this encounter? We're being honest about our health status. We're being honest about our intentions and our relationship status. And all of that sort of honesty in being able to have conversations with sexual partners about all of those things is key. The third is non-exploitive. And this is important because so many people have been victims to sexual exploitation in one form or another. And this, as we know from decades of research and people's lived experiences, causes so much harm and damage to sexual health and to the psyche, mental health, physical health, you name it. And so non-exploitive means that nobody is being exploited or abused in order to be in this sexual encounter. There's, none of that is going on. It's not abusive and non-exploitive. The fourth is shared values. And this means that we have shared our reasons for being here and we're sort of on the same page, okay? And so for some, it's the sexual encounter is within the confines of, you know, a monogamous marriage. For others, it's we're all here for the weekend gangbang. You know, whatever it is, we're all there for the same reason, and everybody is, again, honest, non-exploitive, they're consensual, and they have a shared set of values around the sexual encounter and whatever that means for them and why that, you know, why we're there. The fifth is freedom from unwanted pregnancy and sexually transmitted infection. And that one's pretty self-explanatory. And the sixth is pleasure. And the order of this list I don't think needs to be prioritized in any particular way, but sex is meant to be pleasurable. My first sex therapist supervisor told me that sex is adults at play, and that stuck with me. And I, you know, really believe that to be true. So at least most of the time, there should be mutual, satisfying pleasure in the encounter. And if it's not pleasurable, if it's painful, if it's abusive, if it's harmful, if it's dishonest, if it's non-consensual, those things need to be addressed. And so working from a sexual health perspective, so long as these 6 principles are met, I don't care who you're doing, what you're doing, how many people are involved, or what's going on. And so I find this a really useful perspective to sort of guide people in making decisions in their own lives about their sexual values, about the importance of sex in their lives, about, you know, their own sexual encounters, so that they can feel like, you know, they're living in accordance, you know, with their own personal values, and everybody's, you know, mutually respected and satisfied and pleasured in the encounters. Okay, so another little tangent, which is when sex gets out of control. And so this is, you know, kind of distinguishing between sex addiction, the impulsive or compulsive perspective, sexual behavior perspective, and Doug Braun-Harvey's out of control sexual behavior perspective. So there's kind of a controversy in the field about whether sex addiction is real, whether it's a thing. There's really a lot of disagreement depending on what camp you're in, and even amongst, for example, the World Health Organization and DSM. So in the International Classification of Diseases, hypersexuality is a diagnosis, but it was also left out of DSM-5 for various reasons. And so the definition of hypersexuality, just summarizing it, is, you know, thinking about, fantasizing about, engaging in sexual behaviors, paying for sex, single encounters, porn, masturbation, etc., anything more than normal, and also the use of the word excessive. Now, as you can guess, the words normal and excessive have a sort of value judgment behind them, and who decides that? Who decides what's normal or excessive? And so, you know, definitions have included those with higher sex drive, you know, in trying to understand what counts as sexual addiction. It's been classified as, you know, an impulse control problem, process or behavioral addiction, severe emotion dysregulation, and the main thing is that it causes significant problems in a person's life. And so how are you assessing for sex addiction? Pretty much the same way that you would assess for any other addiction, or, for example, a substance use disorder. Is it causing significant distress and impairment in your daily functioning? Are there, you know, social and occupational ramifications, legal ramifications, health problems, people in danger, relationships that are being severely negatively impacted? You know, is your work impacted? You know, are you needing increasingly stimulating encounters in order to feel satisfied? Things like that. The sort of problems with these are that there's a lot of moralizing and shaming that can go into classifying someone as a sex addict. And so, you know, I've noticed this a lot in you know, more conservative states. For example, the most conservative states have the highest rates of online porn abuse and sex addiction diagnosis and treatment centers. And so, you know, it's sort of an interesting observation that there's sort of a cultural component to it. Another thing is that, you know, this idea of excessive or certain behaviors that are pathologized as sex addiction often pathologize pretty normative behaviors for certain communities, for example, gay men. And so it ends up overly pathologizing a particular community of people, which is marginalizing and discriminatory. You know, a lot of times there are desire discrepancies between partners. One partner has a much higher desire than the other partner or partners in the dynamic. And because of that, it causes conflict when one person wants it more than the other or others. Then, you know, the others can sort of feel like, well, you must be a sex addict because you want it all the time. And so again, there's a judgment piece there. There also may be an erotic inner conflict. For example, ego dystonic identity issues, engaging in same-sex behavior when that's against your religion, or engaging in encounters that, for example, pay for sex or things like that, where you feel any guilt or shame about it. It's you know, sometimes easier to take on this identity of, oh, I must be a sex addict, than to really come to terms with another part of potentially an identity or you know, preference issue that is something that you don't value or don't want for yourself. And so in sex addiction and other sex therapy, a lot of times, you know, we're helping clients to sort of come to terms with these things, whether they just be behavioral and sort of normalizing behavioral differences and variation, or whether it be an actual identity and coming to terms with that part of your own sexual identity. And so a lot of times people will take on this label of sex addict instead of dealing with those inner conflicts. And there's honestly the issue of sometimes it's easier to say, well, I'm a sex addict, and let go of personal accountability in making healthier choices in your life. So there's a lot of variation. There's a lot of controversy. You know, a medical model would say in you know, the pure science of it, we can't really measure tolerance, and you know, there's no withdrawal, and so therefore it can't be an addiction. The sort of behavioral addiction, process addiction camp would say that it is an addiction. And so again, there's just a lot of controversy about how we're defining sex addiction, who's getting labeled as a sex addict, and whether it's even an addiction at all. And so Rory Reed said it's no more about sex than an eating disorder is about food, or pathological gambling is about money. And I think that that's an interesting way of looking at it, is that, you know, there are deeper underlying processes here that are driving this issue. It's not just about the sex. So, you know, again, the neuroscience camp will describe it as the process or natural addiction. Patrick Carnes is a notable sex addiction therapist and you know, kind of a founder or premier model of sex addiction treatment. And he defined it as a pathological relationship with a mood altering experience, which, you know, we can kind of look at any addiction in that way. And Carnes recommended using the SAFE formula to determine if sex is addictive or not. So the first is secretive. And again, this kind of goes against the honesty and consensual, non-exploitive values of the sexual health perspective. Abusive to self or others, same thing, again, looking at the consensual and non-exploitive components of sexual health. The F is it used to avoid painful feelings? So this is where we're looking at, is it kind of a coping strategy or an escapism or avoidance strategy? And then E is empty of caring or committed relationship. And so if it meets all four of those, then he would say that it's addictive. Many people will call the E into question because a lot of people engage in sexual activity and encounters devoid of a committed relationship, and are fine with that. And so looking at, you know, a lot of kink practices, a lot of, you know, hookups or single encounters, things like that, again, you can follow those sexual health perspective values and, you know, have perfectly healthy, enjoyable sexual encounters, even outside of the context of a committed relationship. So here's where that value judgment comes into play, and why a lot of times certain sexual behaviors and relationships and people, I would even argue to say, get sort of labeled as a sex addict, when it's, I think, more harmful to do so. It does more harm than good in a lot of cases. Sex addiction camp will use the language of addict, and that labeling can be helpful, but it can also be harmful in introducing a fair amount of shame and stigma. And so I just want to caution people about that. Treatments for sex addiction are varied. I know a lot of treatment centers incorporate like shame resilience, Brene Brown's work, cognitive behavioral therapy. There's a lot of 12-step program integration, so Sex Addicts Anonymous, SAA groups, and their inpatient treatment centers as well. So as opposed to addiction camp, the ICSB camp sees problematic sexual behavior as an impulsive or compulsive sexual behavior. So it's a clinical syndrome characterized by the experience of sexual urges, sexually arousing fantasies, and sexual behaviors that are recurrent, intense, and a distressful interference in one's daily life. And this can be broken down into paraphilic versus non-paraphilic. Paraphilic is, you know, quote unquote deviant behavior, things that violate the consent of other people, or are, again, on any of those sexual paraphilias in the DSM. Again, there's a judgment component that can come along with that, so I want you to be mindful of that. Versus non-paraphilic, which is normative behavior, which, again, there's that value component in the judgment piece of who decides what's normative. And it's seen on a continuum of, you know, overly impulsive or compulsive and problematic, and on the other end of the continuum is healthy or non-problematic. And, you know, this camp is really looking at problematic sexual behavior as a problem with impulse control and being compulsive with that. And so underlying that is a lot of emotion regulation and coping. And so if you're examining it from this perspective, you're going to be really looking at those issues in a person's life and how they manage their impulse control and what their coping strategies are, introducing you know, a wider repertoire of coping skills so that sex or whatever sexual behavior they're engaging in that, you know, for them is causing problems in their lives, you know, that's not their only coping skill. So you can kind of think of it on a continuum, you know, whatever the issue is, whether it be certain kinds of sexual encounters or the number of sexual encounters, you know, or activities, you know, on one end of the continuum, you know, it's never done. And then on the other end of the continuum, it's gotten completely out of control. You know, anywhere in between there is sort of seldom, recreational, you know, non-problematic at all. And then getting towards the other side of the continuum, getting more problematic, so then it's compulsive and the person feels like they can't stop or they feel compelled to do it. And then out of control is really causing significant problems in their daily life and functioning. And the person themselves, you know, him or herself feel like this is out of control and I can't stop it. And that's really when inpatient or more specialized and time dedicated outpatient treatment is recommended. Ron Harvey describes it as out of control sexual behavior. And, you know, he really addressed the limitations of characterizing problematic sexual behaviors as addiction. You know, really specifically some of the things that I've talked about a little bit earlier, you know, how labeling sexual behaviors as addiction really reinforces problematic, moralizing, stigmatizing social discourse, which, you know, there's no problem with morals, of course, but when you're using that to shame somebody else and stigmatize behaviors that may not be problematic for the person. They may be quite pleasurable and honest and enjoyable, and everybody's consensual and all of those things, but somebody else is placing a value judgment that, there's something wrong with that behavior. And that can really perpetuate this discourse, which we already have in our society, which is, shaming and stigmatizing about sex and sexuality. And so what that does is that leads, people to feel quite ashamed of themselves for engaging in sexuality and sexual behaviors when it's really unnecessary. And, something that is important to note on this is that when people feel shame, they don't stop doing the behavior, they just do it more, and they do it in secrecy. And so this kind of creates a cycle where, their sexuality, they feel so much shame and guilt for it, and they feel stigmatized and judged. And people cope with shame by trying to make themselves feel better often. And so one of those ways is eating or more sexual behaviors or, whatever the problem is. Brene Brown talks about this in terms of, if I feel overweight and I feel like I'm, being shamed for being overweight, and somebody shames me for eating chocolate ice cream, I'm not going to stop eating the chocolate ice cream. I'm going to go eat the whole gallon, but I'm going to go do it in the closet and feel a bunch of shame about it. I'm summarizing her, but it's the same kind of thing in terms of this. And so, because of a lot of the, I want to be mindful of not shaming religion or religious institutions, because there's an incredible amount of value there and can be a lot of sex positivity there, and often is. On the other hand, though, the darker side of that is that often coming from very conservative religious backgrounds, there's a lot of shame and guilt about sex. And so when people feel that shame and guilt, they, often engage in more compulsive sexual behavior. And so, it just kind of sets up this cycle that we create a context in which you feel ashamed of sex. So then you engage in compulsive sexual behaviors to manage the shame, and then we label you and stigmatize you for it. And so it becomes this really vicious cycle. And so, that's that first point in reinforcing that problematic discourse. The second thing is often labeling someone as a sex addict mislabels, what's typical or normative sexual development and behaviors of gay and bisexual men. And so again, this really sets up this process of marginalizing a population that, doesn't really need any more of that. And so, a lot of behaviors, hookups, for example, relationships or hookups outside of the context of a relationship, it's very common, it's, normal. And again, as long as those 6 principles of sexual health are being followed, it's sort of, it's not a problem. But the sex addiction label makes it a problem. And then again, sets up that stigma. Third point is that the disease model for addiction is not verified for this process. And so we've given it a label without having adequate research to really support that. And so, basing conceptualizations and treatments based on this disease model, when it's not verified for that, can also be problematic. And finally, it tends to kind of place all atypical sexual behaviors and practices under this meme of sex addiction. If somebody, it's like, if I don't like that, or if I judge that, then I'm just going to call it sex addiction. And so this, sex addiction gets kind of caricaturized under this like meme of sex addiction. And it can be a slippery slope of who's deciding what's okay and not okay, what's normal and what's not normal. I would argue that all sexuality it's not politically correct. It's deviant. It's different, right? Every person is different. Every person has their own sexual fantasy life, their own behaviors, their own desires and yearnings, and most of it is not politically correct. Let's just be honest about that. And so to kind of put these labels on people can be really damaging, when really we can embrace, the broader, beauty of individual eroticism and erotic desire, then we can free ourselves from a lot of the shame and stigma that come from, being sexual people. Okay, so surprise, you're not just a sex therapist. So these are a lot of the things I didn't expect to need to know when I decided to specialize in sexuality. Pretty much the entire DSM forwards and backwards. Often people come to therapy for a sexual issue, but that's the reason they're coming is because whatever, underlying issue is happening, whether it be, a biological or a psychiatric disorder, the manifestation or the outcome is that it's affecting their sex life. And sex is, hugely important in people's lives. And so when that's not working, it can be a major source of distress. So oftentimes, people come in presenting with, a sexual problem that they're wanting treatment for, but then I find an underlying psychiatric disorder, anywhere from untreated OCD, anxiety, depression, a lot of trauma, and not always sexual trauma. In the next presentation I'm going to be giving is about, what's trauma got to do with it in terms of sexual health and functioning. Even non-sexual traumas, people often think of rape and sexual assault as affecting people, and childhood sexual abuse is affecting, adult sex lives, but all kinds of trauma affect sexuality. And so knowing a lot more about that. Also, untreated sleep disorders and even dementia, neurocognitive disorders. So people will come in with a sexual issue and you have to look beyond that and figure out what's going on behind that. What else is happening, and be able to triage and treat the most relevant or most pressing issue first, and then you can address the sexuality. And sometimes you can address, the issues through sexuality. Psychotropic and medical pharmacology. Medications affect your sexuality significantly. And this can be anything from diabetes and blood pressure medications to psychotropic medications, everywhere in between. I've had to learn a lot more about medications than I ever thought I would need to know, which is pretty exciting. And that kind of piggybacks on the next one, which is, a lot of medical conditions. Countless medical conditions affect sexuality. And so, something that I've learned a lot about is that, when people come in for a sexual problem, that it's really important to have a full medical evaluation, a physical, so to speak. Another tidbit that'll be of interest is that when middle-aged men come in with new erectile dysfunction, I usually send them for a stress test and a cardiovascular workup, because it can be a sign, an early warning sign of cardiovascular disease. That's just one example. A lot of autoimmune conditions affect sexual functioning, even food sensitivities and food allergies. So, coming at this from a very holistic perspective, it's really important to get a full history with your clients. It's not just about the sex and whether or not the plumbing works. There's a lot going on in the mind and body in that integration that really affects people's sexuality and sexual functioning. Not to mention, the nature of relationship. The role of intergenerational and developmental trauma. This is huge, and that's going to be the topic of the next presentation that I give, is just really the impact of people's upbringings, and especially if there's developmental trauma, and that's sort of that chronic and persistent chaotic and traumatic stress that can be present in abusive households. And PTSD, chronic PTSD, even if it's not diagnosable PTSD, the lasting effects of those developmental traumas, as well as the intergenerational traumas and things, the lasting legacies of people who have, survived natural disasters, children of refugees, and asylum seekers. I've worked with survivors of torture. They and their children, adult children, have sexual difficulties, years and years and years later because of those traumas. You know, it really plays a role in a lot of people's health and vitality and feelings of safety in their bodies. Child development and attachment. I never wanted to work with kids, and my first couple of years of training in clinical practice were working with kids, and I would never change it because the adults that I see those 3, 4, or 5-year-olds sitting on my couch in terms of the unmet attachment needs and attachment styles that come into play in sexual relationships and dynamics. You know, again, it's all related, it's all integrated, and impacts people's sexuality. So this is just a list of the main presenting problems that people come into my office with when they come for sex therapy. All right, in no particular order. You know, the colors don't mean anything in particular except for aesthetic preference, but they're not categorized or in any particular way according to color. But yeah, these are just the main issues that come up in presenting problems. I would say the number one is discrepant sexual desire. What often a couple will come in and one person is labeled as, you know, I have low sexual desire. And often upon assessment, it's not actually low sexual desire, it's usually a desire discrepancy, which is a dynamic. It's not a label of one person, you have low desire, it's more of, in this particular dynamic, you are the partner with lower desire. You could be in another dynamic and be the person with higher desire. So it's a relative position. And David Schnarch talks a lot about this in Intimacy and Desire, if you're interested in that. But this is probably the most common issue that I particularly see. Disagreement in SEM use, that's sexually explicit material. I talked about porn earlier. I use the word porn because that's what most people use and understand, but that word has a connotative value that, you know, evokes a lot of judgments in people. And so, you know, I talk with clients a lot about sexually explicit material and sort of destigmatizing and normalizing people's interest in sexual imagery. I mean, time immemorial, our most ancient cave paintings portray sexual material. People have always been fascinated with creating, you know, sexually explicit imagery. And so, you know, kind of looking at people's values about that and about disagreements in the relationship and what it means for each person. Marty Klein has a good book called His Porn, Her Pain, and David Lay got a fantastic book, Ethical Porn for Dicks, love the title. But those are really great books that you can read and recommend to clients who are struggling with, you know, disagreements on sexually explicit material use. A lot of specific sexual dysfunctions, so erectile dysfunction, premature ejaculation, dyspareunia, what traditionally was called vaginismus, and now we have this really fun, long, complicated name of female genitopelvic pain penetration disorder. You know, things like this, those specific sexual dysfunctions and treatment of that. And that's more of the traditional Masters and Johnson sex therapy camp in dealing with those issues. A lot of mental health challenges interfering with sexuality. So again, OCD is a big one. You know, I see a lot of OCD limiting people in terms of their sexual behavior because of certain sensations or smells just can't be tolerated. You know, there has to be, you know, a very specific process which limits spontaneity and, you know, sort of the organic process of sex. You know, really problematic intrusive thoughts and the rituals that go along with that can really interfere with people just enjoying their sexuality, and partners find it particularly challenging as well. Anxiety, depression, you know, dementia, PTSD, even ADHD. I think all those things, any of those mental health challenges can really interfere with one's enjoyment of an ability to be present in their bodies for, you know, healthy and satisfying sexuality. probably 100 times a day I get asked this question, is this normal? The answer is yes. Pretty much everything is normal. Normal isn't always good, and normal isn't always bad. So, just really a lot of myth busting and a lot of education. So I provide a lot of sexual education to clients, and I use diagrams, I use puppets, I use all different kinds of things to kind of teach people about their bodies and really limit that shame and stigma and increase comfort. Out of control sexual behavior, what people call sex addiction. I will sometimes refer out for that, especially if the person is really embedded in that sex addiction language and terminology and 12-step program. I don't particularly follow that. And so, I'm a big fan of treat what you're competent in and refer out for everything else. So I do a lot of that, but if they're not firmly ingrained in that language, then I do help a lot of people with out of control sexual behavior, whatever behavior it is that feels out of control for them. Inexperience. I get a lot more of that here in Texas than I did in California. It tends to be, more conservative. A lot of people wait until marriage, and that, is a wonderful thing. And there's often a lot of questions and problems that arise just from a lack of awareness and knowledge and education. And so that work is really a lot of fun, and sort of teaching people about their bodies and giving them resources to learn about their partner's bodies and preferences. And it's really fun work. Relationship problems that are impacting sexuality. This is a big one. Before you diagnose any sexual dysfunction, assess the quality of the relationship. What's their level of respect and care for each other? What's their communication dynamics like? I do a lot of couples therapy, and, you can do couples therapy, and a lot of times if you resolve the relationship problems, the sex gets better on its own, but that's not the case as often as a lot of people think it is. I can't tell you how many times people have a fantastic relationship, but their sex life sucks. So, a lot of times, yes, you fix the relationship problems and their problematic communication dynamics, power struggles, etc., then sex figures itself out, but that's not always the case. Perinatal related issues, a lot of pain and discomfort, your body changes, body image comes into that a lot. Sleepless nights, imbalance of, what's the word? The sort of division of labor feels imbalanced and unfair, and that can cause a lot of relationship issues, postpartum depression and anxiety, things like that. Infidelity is a big one, and really helping people with their erotic recovery after infidelity. If they decide, to stay together, how do they reconnect, and how do they learn from the infidelity and figure out what the meaning was there to, understand and learn from it and bring, those elements into their own relationship. Body image concerns come up a lot. Shame, I've talked about. Age-related changes. As we get older, our bodies change. Things slow down, things get a little less sensitive, hormonal changes, medical illnesses, diagnoses, cancer, prostatitis, a lot of different issues that come up, menopause, that our bodies change and they function differently. And that sometimes can interfere with sexual functioning, but a lot of times it's the mentality behind it. There's a lot of shoulding, I should be able to do it in this way or for this long, and those sorts of things. And so again, a lot of education comes important. Trauma I've talked about, and I'll give another presentation on that, but trauma really impacts a person's ability to feel safe and comfortable in their own skin. And if your body isn't safe, sex is embodied. it's the body, and its body's intertwined. And so if your body doesn't feel like a safe place, and if pleasure isn't, familiar or safe or accessible, sex is going to be really problematic. And so that's a big one that comes up. And then health conditions I've already talked about. So as sex positive therapists, these are the things that we really aim to help people with. Reducing the shame and stigma about sexuality. Humans are sexual creatures. We are sexual beings, and there's nothing wrong with that. There's a lot of beauty in that. And whether it be cultural or societal or personal, I think it's really important to reduce shame and stigma. If the shame and stigma is coming from a religious background, particularly one of Christianity, a great resource is Dr. Jennifer Konzen. She is an evangelical Christian and sex therapist, and she wrote a book and made a podcast with the same title of The Art of Intimate Marriage. And she really dives into the scriptural components and support for, pleasurable sexuality and reducing shame and stigma and building empathy between partners. So I highly recommend her work. It's really valuable for that. Learning accurate sexual education, naming parts and learning about the body and learning, what the body is supposed to do and how it functions, and, debunking a lot of the myths that people have. Overcoming the harmful messages and rules that people learn about themselves, about their bodies, about sexuality. Again, I'm not going against value systems in particular and saying, that's wrong, but instead helping people to overcome the harm and the hurt that has come from any particular value-based shaming or, for example, people who have shame about being sexual or having sex or being told their whole life that sex is wrong. And then engaging in sex that leads to a lot of shame of like, well, if this is wrong and I'm doing it, there must be something wrong with me. And so kind of overcoming some of those harmful messages and rules. Reconnecting with partners or connecting with partners in the first place, and also connecting with yourself. I believe that each person has their own individual sexuality, and people choose who they want to share that with in partnered sexuality. But being able to nurture your own and understand your own sexuality is really important in showing up for a partner. And so those two go hand in hand. Empathy is one of the biggest things I work on. Research shows that when there's more empathy in a relationship, sexuality, the sex life is better. I'm not surprised by that, but a lot of people are. And so, really helping people to learn how to show empathy and to feel more empathy for one another really boosts the sexual connection. Self-care. A lot of people who feel guilty about experiencing pleasure or taking care of themselves really struggle with sexuality. And so getting people on board with really nurturing self-care and self-compassion is really critical in sex therapy. Working through trauma, learning how to feel safe in your body, learning how to enjoy your body, super important. And managing mental health challenges. A lot of times this is, medication compliance, it's self-care regimen, it's diet and exercise, it's, cognitive behavioral therapy. I'm more of an experiential therapist, but I bring in CBT as well. And so, really helping people to manage their mental health challenges so that they can show up and enjoy their sexuality. And helping people to enjoy their bodies. Bodies are pretty miraculous things of all shapes and sizes and functions and, ability levels. They're still pretty miraculous. And so learning to enjoy the body that you have and live in the skin that you have and find pleasure in the body that you have, that can be quite a journey for a lot of people. Okay, so how can you do it too? I really like this Plicit model. This model is a way for all therapists to kind of identify what can I treat and what can I deal with and how, and when do I need to refer? And so, the levels, the P is for permission, the LI is limited information, SS is specific suggestions, and IT is intensive therapy, and so that's the implicit model. And as you go down this list, there's an increase in time, depth, and intensity of the work. And so the first level is permission. So just often giving permission to do something or talk about something is enough. So a lot of times people don't have the permission to talk about sex. And so by you, the therapist, giving them permission by asking about, how's your sex life? Or how is this issue impacting your sex life? Just giving them permission to talk about it sometimes can open up enough of a conversation that the problem is resolved or gets resolved pretty easily. Okay. Another thing is, giving permission for certain things. For example, most women can't reliably reach orgasm without clitoral stimulation. And so this kind of is both permission and limited information. I've given them a fact, but I've also said, hey, that's normal, that's okay. That is a way of giving permission so that someone can say, oh, okay, there's not something wrong with me. And so again, that can be enough to resolve the issue or to work towards resolution of the issue. Limited information, this is education. So, a lot of bibliotherapy, books, giving people specific information about their body, about their anatomy, about their functioning, about what's expected. For example, most men, as they get older, specifically middle age and beyond, it often takes a little bit more stimulation to achieve an adequate erection. Sometimes the erection isn't quite as hard as it used to be when they were younger, and often the refractory period, or the time between the last orgasm and the next erection, gets longer. And so a lot of times people don't know that, and they feel like, oh my gosh, there's this problem, when really it's normal. And so giving them that information can be enough to be like, nope, that's actually normal. That's okay. That can resolve the issue for the person. Specific suggestions. This is things like recommending certain things. For example, if dryness is an issue, recommending use of synthetic lubrication. For example, if there's an injury or a back problem, recommending certain pillows or wedges, things like that, to augment their experience or to sort of help. Making a specific suggestion about reading a book or watching a particular video, things like that, where you can give suggestions for people to try, knowing that they're going to be, reasonably, a reasonably well expectation of success on that. A lot of times that can be enough to resolve the issue. Now, if all of this is done and the problem is still there, then you know that maybe this is an indicator that the people may need more intensive therapy. And that's when you can know to refer to a sex therapist. And so for the PLISS parts, if you're wanting more information, I will attach a book list, a bibliotherapy list for all different kinds of issues and populations. So that will be part of the sort of PDF attachment for this presentation. So you yourself can educate yourself on some basics of sexuality, and then you can be equipped to give permission, to give some information, to give some specific suggestions. And then if those things really don't help and the issue persists and it's really causing distress or impairment in someone's life, then refer to a sex therapist. And if you are interested in specializing in sex therapy or going more in depth with the intensive therapy aspect, this is one approach, theoretical approach to sex therapy and specifically systemic sex therapy. And so the authors, Hartlane, their names are escaping me right now. They'll come to me in a minute. I apologize, but they have written a couple of different books on the intersystems approach to systemic sex therapy. And these, the domains of an intersystems approach are the individual domain. And so these are the domains that you'll assess and treat. And so one is the individual. So this is both biological and psychological. So their health history, any injuries, major surgeries, chronic conditions, overall health level, mood, anxiety, trauma, or other mental health challenges and disorders, diagnoses, or just challenges, and then even attachment styles. But really looking at each individual in the dynamic of what's going on with them in terms of their mental, emotional and physical health, and looking at how that is affecting the sexual and the relationship. Also the couple domain. This is the relationship dynamics. And so what kind of relationship is it? What's the quality of the relationship and each person's role in functioning, their perceptions of safety within the relationship. Is there any sort of abuse going on? Really the nature, the degree, the expressions of love, respect, admiration, kindness. If those things are missing, then that's obviously going to be playing a role in some of the relationship problems and even sexual problems. If those things are there, how are they expressed, and is it enough? And that can be a really good foundation to start sex therapy on, when those things are there too. So, I often tell couples when they do show those things, to have a good degree of love and respect for each other and kindness and empathy. I tell them, like, hey, you're in a great place. That's going to save us a lot of time. And if not, then we do some groundwork on that, and we just spend some time on really building those things up while we're addressing whatever sexual issue they're presenting. Is there any history of infidelity or mistrust, violations of trust? Looking at their communication and interaction dynamics. EFT therapists, for example, will be looking at their cycle or their sequence, and what's going on there. Is there a pursue distancer dynamic? Are there sort of parental dynamics in the relationship? Whatever's going on there from whatever theoretical approach you use in working with couples, you're really looking at the couple functioning. The third domain is the family of origin and intergenerational influences, and how are they treated during, before, during, and after puberty. This is a big one. I look at, a lot of times, for example, girls, once they hit puberty, their dads stop touching them. They stop wrestling and, roughhousing and that sort of thing. And so a lot of women feel like there's some shame and loss associated with their developing body. I look at how did their family express certain emotions and affection. Did they have a healthy example of an affectionate relationship, a kind, caring, respectful, loving relationship? What did they see, right? And I talk a lot about, what was your coaching? What kind of coaching did you have from your family of origin about how to do relationships? What were the lessons, the rules about sex, whether they be spoken or unspoken? And where did these rules come from? Did they come from society? Did they come from your peers? Did they come from, your church, your parents, your culture? What were these rules about sex? And what did you learn from that? What kind of sex education did they receive or not receive? And so, how much knowledge do they have? Any sort of developmental trauma, family rules and dynamics, not only around sex and affection, but outside of that. In particular, the expression of emotions, various emotions like anger and sadness. What did they learn about how to treat those things? Sex brings up a lot of different emotions in relationships. And so what kind of coaching did they have on how to express and manage those emotions? gender roles and gender role expectations. I look at all of these things and how it's going to be influencing their relationship process and how they manage their sexual relationships. And then finally, the overarching cultural context, history, religion, the basic or the broader contextual factors, cultural beliefs, rules about sex, again, and this is on that sort of broader, more meta level of the societal influences and the cultural influences, not just specifically within the family. Any intergenerational patterns, intergenerational influences, historical trauma, historical events, racial and ethnic-based trauma, and how that affects individuals and what they've learned about the world and who can be trusted and what relationships are like and the safety of affection and sex and things like that. And if you like this approach, Hertling, Weeks, and Jambesha are the authors of this model. And then there's another approach, as a sort of side note, Stephanie Bueller, she's in Southern California, I want to say Santa Ana, and she's got an institute and training for sex therapy certification. And her book, What Every Mental Health Clinician, I think, needs to know about sex, she takes an ecological approach, ecosystemic Bronfenbrenner approach to sexuality. So that's another model that you can use as well. So in closing for today's training, I want to quote Mr. Rogers. Anything that's human is mentionable, and anything that's mentionable can be more manageable. And I think that this really applies to sexuality and sexual difficulties, whether they be in an individual or relationship context. If we can talk about it, we can manage it. Sort of this idea of name it to tame it. Sex is human. It's a part of our lives. Every human has a sexuality, even if it's asexual. And so being able to talk about it, being able to interact around it, being able to have a conversation, and to know that there are professionals out there who are trained to help with this. If we can talk about it, then we can manage it. And that's all I have for you today. Thank you very much for being here. Again, I'm Dr. Nicole Van Ness, licensed marriage and family therapist. I just want to thank you for participating in the training. If you have any questions for me at all, please don't hesitate to contact me. My email is connectedcouples1, that's the number 1, @gmail.com. And my website is www.connected-couples.com. Thank you.